Zoom, via Facebook Live, as well as on YouTube. Thank you very much, everyone, for continuing to join. Thank you very much for all the feedback that you've been giving in helping us formulate these series and these continuing education series to meet the needs of our members, as well as to educate anybody who's watching this and who is in need of medical education. Just to let you know that by the end of today, we would have given out 20 continuing medical education credits in this month, in the past month, which is really, thank you for the overwhelming support and the encouragement. And thank you everybody for participating. While these are some uncertain and troubling times, we've tried to make the best and most out of this time that we have together by connecting through various means, new technologies, new platforms, to make sure that we're up to date with the most relevant and scientific and accurate information about this COVID-19 pandemic as it pertains to various aspects of our health. Today we have a very special guest and lecturer. She's a world-renowned physician, known to us. We were delighted to have her during the 11th Armenian Medical World Congress, which we hosted here in Los Angeles. Dr. Carolyn Apovian was one of the keynote speakers. Just to say a few things about her. Her CV is a very long and accomplished one. Dr. Carolyn Apovian is a professor of medicine and pediatrics in the section of endocrinology, diabetes, and nutrition at Boston University School of Medicine. She's also director of the Center of Nutrition and Weight Management at Boston Medical Center. Dr. Apovian is nationally and internationally recognized authority on nutrition, metabolism, and obesity medicine, and has been in the field of obesity and nutrition for nearly 3 decades. Her current research interests are in weight loss and weight gain and its effect on adipose tissue, metabolism and inflammation, obesity and cardiovascular disease, resolution of diabetes and cardiovascular disease in the bariatric surgery population, disparities in the treatment of obesity in underserved population, and novel pharmacotherapeutic agents for the treatment of obesity. She's also an expert in the research of techniques for sampling subcutaneous adipose tissue and muscle biopsies, and has been studying the relationship between adipose tissue inflammation and obesity for over 15 years. The Center of Nutrition and Weight Management under Dr. Apovian's direction has specialized in the assessment and treatment of obesity and its comorbidities, with a focus on underserved populations, and the center sees a widely diverse ethnic population. Dr. Apovian has written over 10 books and over 200 peer-reviewed original research and review articles on obesity and nutrition. Dr. Apovian was a member of the expert panel for updating the 2013 clinical guidelines for the management of overweight and obesity in adults, published in Circulation and Obesity Journal, and was the chair of the Endocrine Society Guidelines for Medical Treatment of Obesity, published in the Journal of Endocrinology and Metabolism in 2015. Dr. Apovian has given over 150 invited lectures nationally and internationally, and most recently served as immediate past president of the Obesity Society from 2018 to 2019. Dr. Apovian is one of the founding creators of the American Board of Obesity Medicine and is the director of the fellowship program in obesity medicine and nutrition at Boston Medical Center. I am truly delighted to welcome Dr. Apovian back to Los Angeles, of course, via this Zoom platform. And Dr. Apovian is going to talk to us today on obesity as it pertains to the COVID-19 pandemic. Dr. Apovian, I invite you now to please take over this platform. Please engage your video and your microphone, and this platform is yours. Thank you.
Thank you so much. Can you hear me?
Yes, we can hear you.
Dr. Sepilian, thank you so much for that overwhelming introduction. I hope I can really do some justice to this pandemic to identify why we have issues with certain with obesity and with the elderly. And let me just try to share my screen. All right, how's that? I'm sharing.
That is perfect.
All right, so. All right, everything okay? You can hear me?
We can hear you and we can see your screens beautifully. Thank you.
Wonderful. Okay. It's my pleasure to be here today in Los Angeles. I'm sitting in my home in Newton, Massachusetts, where we're really in the middle of this pandemic. We're still we're starting to see some decreases in our ICU admissions, but then we have some blips up and down, and worldwide. So a few weeks ago now, April 20th or so, I spoke about this topic. And at that point, we had confirmed 2.4 some odd million cases worldwide and 165,000 or so deaths. And in the United States, we had confirmed over almost 800,000 and 41,000 deaths. We're now only a few weeks later, May 4th, 2020, May 5th, 2020, and worldwide, we have over 1 more million confirmed cases with double the amount of recovered cases, unfortunately, 258,000 deaths. And in the United States, confirmed now 1.23 million, of which 164,000 are recovered, but 72,000 deaths. So this has brought all of our healthcare systems to their knees as we fight this pandemic. And what I'm going to specifically focus on is why are we seeing this association with obesity, which we define with the body mass index. Your body mass index is your weight in kilograms over your height in meters squared. Most people know what a BMI is these days. If your BMI is over 30, you have obesity. And if your BMI is over 25, you are overweight. In this pandemic, we have seen that there are cases who go to the ICU and need to be intubated who have extreme obesity, meaning BMI over 35 and over 40. And we'd like to understand why this is happening. So now, you all remember, I think, many of us remember the swine flu epidemic. April 2009 to January 2010, there were millions of people infected and between 8,000 and 17,000 deaths. And again, at that time, there were reports from around the world identifying obesity and severe obesity as risk factors for hospitalization and mechanical ventilation. So we saw this threat 10 years ago that the H1N1 influenza or swine flu also did this. So there are several reasons for why, certainly back then, we realized why severe obesity was creating this impact on severity of H1N1 influenza or the swine flu, and severe obesity. So in severe obesity, you have what's called hypoventilation of the lungs. And so your breathing pattern, when you do pulmonary function testing, you have a decreased expiratory reserve volume and functional capacity. You don't have good compliance. So the work of breathing becomes more difficult. In addition, if you have a lot of fat around your abdomen, your pulmonary function is further compromised because that fat will push up into the lung area, decreased diaphragmatic excursion, and again, making ventilation more difficult. All right, so those are the anatomic reasons why obesity and this respiratory target for the respiratory system is associated. There's an association there, but that's not all. So we have an anatomic reason for why patients with obesity are having more trouble with COVID-19. And that's also true in our elderly. So the elderly also have decreased pulmonary reserve. But we're seeing young patients with severe obesity being very affected by COVID-19. And we saw that was true with H1N1 influenza causing pneumonia. Those are two things. There's also a chronic inflammation that is associated with obesity, and that's what we study in my lab. And we have shown that obesity, especially abdominal obesity, which we call visceral obesity, which is adipose tissue or fat tissue where it's not supposed to be. Where is it not supposed to be? Fat tissue can be a very protective organ around the gluteal area, the thighs. It can be protective, and those fat depots, those adipose tissue depots, are protective and they do not cause inflammation. However, the fat depots that occur in the abdomen, around the organs, in the liver, in the pancreas, around the heart, around the kidneys, is detrimental to other organs because those fat cells produce cytokines. We call these inflammatory cytokines, and they're associated with the type of obesity that is, I'm going to talk to the people who, lay people also, the apple shape instead of the pear shape. All right, that is a type of obesity that is associated with inflammation, and that kind of obesity can lead very quickly to diabetes and heart disease. And we think the chronic inflammation is an association with COVID-19 infection, and more importantly, severity of that infection. So, who's at higher risk for severe illness with COVID-19? We found that those people who are 65 years and older, especially people who live in a nursing home or long-term care facility. Now, why would that be? They're in an area crowded together, and they're older, and we know that they have more of a senescent immune response. And those who have obesity have an immune response that is very much akin or like those who have a senescent immune response who are older. Now, other people who have underlying medical conditions, chronic lung disease, moderate to severe asthma, serious heart conditions, and those who are immunocompromised. So again, this immune system dysfunction are also at higher risk for more severe illness. And then we have the severe obesity, body mass index over 40, people with type 2 and type 1 diabetes, but we're talking about type 2 here, and people with chronic kidney disease undergoing dialysis and liver disease. So I want you to remember all of these organs. So diabetes, the pancreas, the kidney, the liver, fat tissue, the heart, and the lung. Because the way this virus invades the cell is through a receptor that is very prevalent in the cells in these organs. All right. So let's look at some of the data that has been coming out since March about obesity. Obesity is a risk factor for critical COVID-19, and this comes from a report from March 26th that compared the UK, so worldwide, and the UK reported that 2/3 of 196 patients requiring critical care were overweight, and 71 of those patients had a BMI of 30 or higher. 37% of those admissions in through the UK were patients younger than 60, and almost all of those patients were men. And what is interesting about men is that, especially if you're younger and you have obesity, you tend to have abdominal obesity. All right, so obesity can increase inflammation and weaken the immune system. And also, again, the anatomical reasons about excess weight, putting pressure on the lungs and increasing the complication risk. Okay, so that's one of the first studies that came out. When you talk about the United States, and you look at the US obesity prevalence, it has been going up since, certainly since 1999 and 2000. Here are our adults. Now, back in the 1960s, this wasn't the case. In the 1960s, we had maybe 15% of the population with obesity. And then suddenly by 2000, 30% of our population suffered from obesity. And now it's up to 39.6% in adults, less in adolescents. So in total, on average, 35% of the United States has obesity of the population. So this is millions of Americans. We also have seen moderate to severe obesity in the nursing homes between 2000 and 2010, and that also increased from about 15% to about 24%. So maybe we're seeing some of these associations with COVID-19 in obesity in nursing homes increasing as well. And remember, we have an aging population. And in the aging population, we have what's called sarcopenic obesity, which means that as you get older, you lose muscle mass and you gain fat tissue. All right. Obesity seems to be a very important risk factor for younger people in COVID-19. So the reviews started to come in from New York that about 400 patients admitted to Cornell had obesity as a risk factor for admission with COVID-19. And the New York City obesity rate is only 22%, but among the adults that were admitted of those 400, 50% of the younger patients had obesity. So it's an important risk factor in the younger population. We're seeing that play out here in Boston as well. So these patients, 60% of the patients that were looked at Cornell were male. Again, 36% had obesity, age about 62, that's an average age. And 10% had died. So under age 60 with obesity, again, this is from that data. Those patients under 60 with obesity with positive COVID-19 were twice as likely to be hospitalized and even higher risk of requiring critical care. And at the time, by the time we saw this data, in our Boston ICUs, many, if not all, over 60% of our ICU patients had BMIs over 35, so we were seeing the same thing. Now, another issue that had come up, especially in looking at the United States data, were that African Americans and Hispanic Americans and also lower income white Americans were adversely affected by COVID-19 at higher risk of severity. Now, what do we know about African Americans and Hispanics compared to Caucasians? We know that they already have higher rates of obesity. And these higher rates of obesity in African Americans and Hispanics have been purported to be due to, yes, lower SES status on average, however, also a predisposed genetic risk to developing obesity in our current environment, our westernized processed food environment, in addition to close quarters in low socioeconomic areas. So at the time, in April, late April, more than half of COVID-19 deaths in the US have been in New York and New Jersey at the time, but now we're seeing that the South, the regions in the South are being affected later, and we have more obesity in these areas. We have more obesity and we have more diabetes in the Southern and Midwest states compared to the rest of the country. So the percent of diabetes, the darker areas have 12.2 to 20% of patients with type 2 diabetes. That's very, very high compared to New York, New Jersey, and Boston. Those areas are more of the national average of 10 to 12%. Obesity rates in these areas are well over the 35% that is seen in the average in the United States. It's well over that. It's close to 50% here, 48%. Okay. Now, what are the known risk factors for COVID-19 that are higher in African Americans than in whites? Hypertension, also. Diabetes, yes. And a higher prevalence of cardiovascular disease among African Americans if you compare to whites. So they also, on average, have adverse social determinants of health, low SES status, high housing density, rural hospital closures, lack of preventive care, and what is also extremely important, poor access to healthy foods. And we're seeing COVID-19 hit Chicago last month with 70% of deaths in African Americans. In Louisiana last month, 70.5% of deaths in African Americans. In Michigan, 40% of deaths. New York City, 28% of deaths. And New York City Hispanics, also 34% of deaths. So we're seeing a high racial and ethnic disparity. So but also in other parts of the world, even though they don't suffer with obesity the way we do. We saw in China that those with higher BMIs were had more than twice the risk of severe pneumonia. 88% mortality of 17 COVID-19 patients who died, 15 were either overweight or obese. Now in China, obesity occurs at a lower BMI because at a lower BMI, patients of Asian descent have more visceral body fat. Now in Louisiana, 60% of patients hospitalized with COVID-19 had obesity and doubled their risk of requiring a ventilator. In New York City, this is, so far we have the largest set of data that was published, not in a peer-reviewed journal, but out there, again, a few weeks ago, over 4,000 patients, NYU Langone Health. And they looked at risk factors for admission, and definitely the big two, age over 65 and obesity. So of over 4,000 patients, 2,000 hospitalizations. We had the strongest hospitalization risk being age, and then BMI over 40. And then third was heart failure. Again, we're seeing heart, diabetes, obesity. The reason why we don't have diabetes here is because it's within the BMI over 40. Now, what other risks did they have? Certainly low oxygen saturation, and then markers of inflammation, D-dimer, ferritin, and C-reactive proteins, cytokine storm. Back in China, in January and February, again, we still saw that those who with higher BMIs had higher odds of developing severe pneumonia, requiring ventilation. All right. Now, we're going to talk about inflammation, but again, anatomic reasons why these patients with obesity and COVID-19 being intubated are going to be a problem, a bigger problem. Patients with obesity are very, very difficult to intubate. That's one barrier. Diagnostic imaging are going to be another barrier because there are weight limits on imaging machines, and we've had that problem for the past 30 years in hospitals. Positioning and transport are also going to be very difficult. And we have special beds and positioning for patients in, let's say, bariatric surgery units, but they're not widely available in other community hospitals, certainly not in all countries, and certainly not in the United States in community hospitals. So we have this additional anatomic and logistical issue. Okay, so when we talk about inflammation in obesity, what is actually going on? This is what we study. So on the left here, we have a schematic of adipose tissue. Here are fat cells, and they're storing fat, and there's a blood supply, and these are called adipocytes. And around these fat cells, we have immune cells. And in the lean state, these immune cells pick up debris and are anti-inflammatory. All right, so CD4 T cells, anti-inflammatory. M2 macrophages are just a type of macrophage that is anti-inflammatory. And normal, healthy fat tissue secretes adiponectin, which protects against diabetes. And they secrete anti-inflammatory adipokines, secretory products that go to other organs and blood vessels and pick up debris and are anti-inflammatory. When you have obesity with mild metabolic dysfunction, let's say you're starting to develop storage areas of fat which are not very healthy. So not just subcutaneous in the thighs, in your subcutaneous abdominal area, but you're starting to develop some fat depots around certain organs in the liver. You get bigger cells, they're storing more fat, and then you suddenly get some inflammatory markers. So the M1 macrophage is pro-inflammatory. CD8 T cells are also pro-inflammatory, and you develop pro-inflammatory cytokines that are secreted from these cells. And then you get more leptin and leptin resistance, which we're not going to talk about today. We're just going to talk about the inflammatory markers, TNF alpha, IL-6, IL-18, and these others, CCL2. Then when you absolutely, this is a patient who maybe is on the way to developing prediabetes and some heart disease and liver fat. Here we have a patient who is has diabetes or prediabetes, and we see that there are fat cells that are dying because they have extruded their fat contents and burst open, and now we have lots of macrophages and inflammatory components coming in here, and you see that the vasculature can't handle this anymore, and you get hypoxia. What happens is the fat cell cannot breathe and dies from hypoxia. The arteries can't supply it. More inflammation, decreased vascular function, and endothelial cell dysfunction in the blood vessels, because these cytokines go into the blood vessels and cause disease in other places as well. Now, if you have a patient who has this chronic inflammation and develops COVID-19, and this inflammation this inflammation is busy doing this, it is not going to be it's not going to be ready to fight off COVID-19. And in fact, patients, we're starting to study patients with COVID-19 and finding that these T cells are depressed. The CD4 T cells are depressed, but so are the CD8 T cells. Those depressed state of immunity is that what is seen in the older population as well. And so that's why we think COVID-19 is causing cytokine storm, intubation, and eventually death in our older population and in those with extreme obesity. So we found this is a real live fat cell that we stained. We took this fat tissue from a patient and we stained it to look for immune cells and fat tissue, and we found these macrophages surrounding a dead fat cell. And these are called crown-like structures. And we found that the more CLSs, crown-like structures, we saw in patients, the more endothelial cell blood vessel dysfunction we found. How did we measure blood vessel dysfunction? We did an ultrasound of the brachial artery, and we gave the patient nitroglycerin and dilated the vessel, and then found how quickly it retracted. And the quicker it dilated and retracted, the healthier it was. And we found that those patients who had CD68 positive, meaning these crown-like structured, had worse brachial artery dilatation right here compared with those who did not have these crown-like structures. So we showed that the more inflammation, the more damage to the vessel you have, the more you're at risk for heart disease. And this also correlated with insulin levels, so that these patients were also at higher risk of diabetes. All right. So now, before we have a discussion, what does all of this have to do with how COVID-19 infects the cells? So again, we were talking about the heart, the pancreas, the liver, the kidneys. These, and the fat tissue. These tissues have the ACE2 receptor in copious amounts normally in the tissue. And this is how COVID-19, the coronavirus, gets into the cell. It invades through the ACE2 receptor, which is normally a very protective receptor. And when it invades the cell, it destroys the receptor. So basically, that's the simplified version of how COVID-19 gets in and how it invades those tissues. Now, if you have a patient who has inflamed fat tissue, you're going to have patients who have less of this fat. Say it's on the fat cell, it's a reservoir. So in other words, fat tissue has ACE2 receptors. The virus is getting into the fat tissue. The virus is also getting into the heart tissue, the lung tissue, the kidneys, and all of the vital organs, especially the lung. And if you have a patient who's inflamed, you're going to have a dysfunctional immune system that can't fight this off. And what we also find is that, now this gets a little more complicated, but fat cells have been found are found in lung tissue in the surrounding areas. And if this fat tissue is inflamed in a patient with obesity, then we could also see the cytokine storm that is causing intubation because of damaged lung tissue. So that's what we think is going on. We have to prove all this. We're not sure. This schematic came out a few days ago, and I thought it was a great schematic showing the ACE2 receptor. Now, again, the ACE2 receptor is protective. If COVID-19 is infecting that ACE2 receptor, it becomes damaged. And those patients with ACE2 receptors in their fat tissue are becoming maybe reservoirs for COVID-19, more severe infection. So I just want to summarize, or I think I want to summarize. Obesity is a top risk factor for COVID-19, especially in younger patients who are admitted and intubated. Certainly in New York City, we see that to be the case. We also see more severe infection in African Americans who have more obesity. The older population is also at risk, and we think that link is from the senescent immune system, which is very similar to patients who are younger with obesity and inflammation. And then in the end, if there's any silver lining in all of this, which it's hard to find a silver lining, this pandemic has certainly highlighted the flaws in our preventive health system. We have failed to prevent and failed to treat obesity from early childhood into adulthood. And we've also highlighted the flaws in our treatment of the elderly in assisted living and nursing homes. So perhaps in the future, after this pandemic has caused all of our healthcare workers to breathe and the research to start on investigating obesity, fat tissue, lung tissue, heart tissue, and COVID-19, perhaps we can identify treatment strategies for obesity early on. And that is why I am devoted to bringing obesity medicine into our healthcare system. So I'm going to stop here and we can have a discussion with questions and whatever you want to do. Thank you for listening.
Thank you, Dr. Apovian. That was really a remarkable talk and very interesting and really eye-opening to so clearly see the link between adiposity and obesity, and as it pertains to inflammation and as it pertains to some of the pathophysiology that's going on as we're beginning to learn more and more about how coronavirus enters the body and what the natural progression of the disease is and why some people are faring so much worse than most are. At this point, I'd like to invite everybody to please pose your questions. If you can place your questions, there are two ways of going about this. There's a Q&A tab at the bottom of your screens, and you may feel free to go ahead and place your questions in the Q&A section. You may also place your questions or comments in the chat box that you see in the bottom, and we will get to your questions as well. If you are watching on Facebook Live, also please feel free to pose your questions in the comments and we will get to your questions. So Dr. Apovian, we have a question from Dr. Arsine Kalfayan, who's a member of our CME committee. And she says, did you see hypotension due to the damage of ACE2 receptors by COVID-19?
That's a great question. And I think, you know, hypotension is part of septic shock and ARDS. And, you know, we really need to study this. We are right now collecting data, collecting blood, and in my case, collecting fat tissue, unfortunately, from autopsies to study what's going on with the receptor. So you have a good point, but I think that in the face of a cytokine storm and septic shock, that the hypotension is really from the cytokine storm and septic shock. But that's just my guess, and we need to look at tissue and blood work in patients with COVID-19.
Yeah, thank you, Dr. Kalfayan, for that question. And, you know, I have to say, Dr. Apovian, my thesis during fellowship was actually the relationship of obesity with reproductive physiology. In fact, I studied adiponectin and leptin, leptin receptor and the soluble form of the receptor as it pertained in various forms of inflammatory state, specifically PCOS, polycystic ovary syndrome. And, you know, this is really remarkable areas, area of medicine, which in my opinion, and we were talking briefly before we started your presentation, that mainstream medicine needs to be much more aware of, especially adipose tissue as an endocrine organ, potentially an inflammatory organ. And now, And you were saying that, you're one of the founding members of obesity medicine. If we can talk a little bit about that, because I'm monitoring on who's participating, and we have a very diverse group of attendees, from general family medicine to specialists. There are some endocrinologists, some medical students even, who are participating. If you can talk a little bit about the field of obesity medicine and how can one learn more about it.
Absolutely. So obesity medicine started, there were a few of us in the field. What I did, I did medicine. I was a resident in internal medicine at one of the Harvard teaching hospitals, the New England Deaconess. And then I went into nutrition and metabolism for my fellowship. And at that time, the treatment of obesity was really, diets and exercise, right? And we had some amphetamine-like drugs, and that was about it. And then bariatric surgery started to take a hold and show great data showing that you can lose weight and keep it off. And then we learned that the reason why bariatric surgery works so well is because obesity is a disease. And as you said, it's a disease. You were talking about leptin and other hormones. Though leptin and insulin and GLP-1 and PYY, there are hormones that come from the fat tissue and from your intestines, from your gut, and go to the brain and tell you if you're full or hungry. And unfortunately, what happens in obesity is these pathways become dysfunctional. And we don't know why they become dysfunctional. And some of us think it's from processed food. Some of us think it's from genetics plus overeating sugar and fat. Whatever the reason, most of us in this environment defend a higher body weight set point, so that when we try to lose weight, all these hormones start to make us really hungry, so we gain it back. That's what the study of obesity medicine is about. We are trying to simulate with medications what we see with bariatric surgery. When you have bariatric surgery, you are creating a small pouch for the stomach, and you're disengaging part of the stomach from the rest of the intestines, and you're doing a bypass of a little bit of duodenum and small intestine. Very little. There's no malabsorption, but what happens is these hormones start to change, and patients who've undergone bariatric surgery feel full with much less food. And so they are able to lose weight and keep it off because they don't have those hunger pangs. So we're trying to study bariatric surgery to see if we can develop a combination of medications that can do the same thing. Now, Miriam Manoukian, Dr. Manoukian has a great question. Can I answer it?
Oh, yeah. So her question is, first she makes a comment saying, thank you for a great talk. She goes on by saying, since intermittent fasting has become very popular, is there anything known about immunity during intermittent fasting?
Thank you, Miriam. That is a great question. So intermittent fasting, there are many types of intermittent fasting, but the one that we are starting to study is called early time restricted feeding. So the idea is that you restrict your food intake during, as much as possible, during daylight hours. And the hypothesis that we're trying to test is, if you eat a certain amount of calories during daylight hours, can you lose weight can you be in better metabolic control than someone who eats the same amount of calories but eats them later in the day? All right. So in order to do this, we have to test 4 different concepts. Eating a low-calorie diet during early daylight hours versus later, or eating as much as you want, but stopping before dusk, and eating as much as you want, eating later on. What we think will happen is that you're naturally going to eat less during daylight hours. But we think that even if you ate more, but made sure you just ate during daylight hours, that your circadian clock is going to be healthier, and you're going to metabolize more calories, burn them off instead of storing that fat. And to answer your question, Dr. Manoukian, there are small reports suggesting that yes, there is reduction in inflammation and therefore improved immunity after this fasting, but we need to figure out if that's due to the weight loss or is that due to when you ate the food. I hope that makes sense.
Yeah, that truly is a very good question. We have a question that has come through from Facebook Live. A viewer who's watching from Philadelphia is asking in regards to patients who were formerly obese, however, are in normal weight now, and their risk and predisposition to COVID-19. If you could comment if there's anything known specifically about that.
Wow, that's a really good question, and we don't know anything about that. But we can talk a little bit about the formerly obese. So those patients, my answer is probably related to how did they get there. We know that if you lost weight by diet and exercise, and let's say you now weigh 200 pounds and you lost it via diet and exercise, and you compare yourself to a patient who was always 200 pounds, that patient who lost weight through diet and exercise cannot eat as much as the patient who was always 200 pounds. So that tells you that there is something about obesity that is beyond calories. There's something beyond it. It probably has to do with how the cells metabolize nutrients and the mitochondria and all of that. And we have to figure out what's going on. But to answer your question, those who lose weight with diet and exercise and they've gotten healthier should not be, if we're talking about obesity causing inflammation and pulmonary hypoventilation, you should be in better shape. If you're reduced, if you used to have obesity, but now you lost weight, no matter how you do it, you should be in much better shape. Right.
And which goes hand in hand with the reversal, some of these metabolic conditions that we see with weight loss, whether it is through bariatric surgical means or whether it is through other means. We have seen instances where prediabetes reverts back to normal, or even, diabetes also can resolve if indeed there is that weight loss there. We have a question and a comment that says, "Hi, Dr. Apovian. It is very nice to see you on this panel. My question is about leptin and whether leptin levels go up or down with exercise."
Thank you, Gardenia. That's a great question. Nice to see you here. So this is a complicated question because leptin levels are directly related to fat tissue, but it's even more complicated than that, because the more fat tissue you have, the more leptin resistance you have, okay? So when you lose weight, leptin levels go down. But leptin levels going down means that it's not, the leptin protects your fat stores. So when leptin levels go down, it signals the brain that you're hungry. Now, what exercise really does is restores leptin sensitivity and insulin sensitivity. And on top of that, cardio exercise does that. Resistance exercise training builds muscle and also builds leptin and insulin sensitivity. So, you know, leptin levels increasing or decreasing is not the point. The point is sensitivity to leptin. You want to be sensitive to leptin just like you want to be sensitive to insulin, so that you can get nutrients into your cell and burn that energy. I hope that makes sense. And I see we also have, are you hearing me still, Dr. Sepilian?
Yes, sorry.
Okay,
I got cut off for a second, but I'm back.
All right. Okay, good. Now, there's another question here, or should we take a question from Facebook or?
Yeah, no, go ahead. Let's take a look in the chats. It looks like I've lost, because I relogged in, I lost all the chats. So if you can.
All right, so I'll answer. Lucine, any comment on gut flora and obesity, please? Thanks. Yes, there's a lot of the obesity and the microbiome has gotten a lot of attention lately, and much research is going on. We know that gut flora is different in those with obesity as compared to those without obesity or those who are lean. We just are not sure whether or not the gut flora changes because of what you're eating or because of the obesity. So it's very, very complicated. We do know that gut flora changes dramatically after bariatric surgery, for example. However, is this a hormonal change? It could be. It could be GLP-1 changing, causing gut flora changing. It could be gut flora changing because of you know, a hormonal change for improvement in gluconeogenesis in the liver. There's so many things that we have to study, but the point here is that all we know is that in obesity versus the lean, there's a gut flora difference, and it may also have to do with inflammation. So, you know what? If you like probiotics and prebiotics, not bad, but we don't know what they do yet. So I think we lost.
In the chats, there was another comment in regards to probiotics, and I think you answered that question. Do you see any other questions, Dr. Apovian, that I don't see anymore? I see Lucy's
In what extent are metabolic changes reversible after weight loss due to bariatric surgery and other means? That's a very good question. So the metabolic changes, you know, the metabolic changes that occur after diet and exercise weight loss that cause patients to have hormonal changes that make it very difficult for them to keep the weight off can be improved by resistance exercise training. So what does that do? That builds up your muscle mass. And when you lose weight with diet and exercise, your resting metabolic rate goes down. The way to increase it back up again permanently is to build your muscle mass, because those are the cells that do a lot of work and will increase your basal metabolic rate. So that's how you can change that. You can also change it after bariatric surgery. When you have bariatric surgery, you do change set points, and we think your resting metabolic rate is not perturbed because of the hormonal changes. However, when you lose weight, you lose muscle mass too after bariatric surgery, and you have to eat your protein and do resistance exercise to make sure that when you lose weight after surgery, it's fat and not muscle.
And does that same principle apply to intermittent fasting in regards to losing muscle mass or breaking down muscle mass during the various regimens of intermittent fasting?
Well, intermittent fasting is a little different, because what we're trying to find out with intermittent fasting is, are you metabolically improved if you fast at a certain point? Is it more physiologic? Are you geared genetically to fast? And do your enzymes and does your metabolism work better if you give it a period of fasting? And we think the answer is yes, but we have to prove it.
Now, there's a question from somebody who is asking, does intermittent fasting work for everybody in terms of weight loss? I think that's what this person means.
Does intermittent fasting work for everyone in terms of weight loss? It depends on what you mean by intermittent fasting. The answer is we're trying to study that. We don't know. Mm-hmm. If you're the type of person who finds it, if you feel better eating your meals before a certain time, let's say before 8 p.m., like we think that intermittent fasting should work well if you're eating and you stop eating at a certain point. We think for most people that's probably a great idea, because what happens when you eat later and later into the evening is you tend to start eating more processed food, desserts, popcorn, potato chips, all that stuff. So you see, we have to kind of separate out what kind of food you're eating late at night. If you're eating chicken and vegetables, maybe that's okay. We don't know. So when we're trying to study intermittent fasting, and in order to do that, we have to make all the groups as consistent as possible.
Yes, I think that it looks like the person is sending a message. So there's another question. Does it also explain rapid weight gain if bariatric surgery failed or reversed versus to weight loss through exercise?
Okay, so again, so we're talking about, we want to know about rapid weight regain after bariatric surgery.
Mm-hmm. It failed bariatric surgery. I'm not sure what they mean by
right.
failed.
So failed bariatric surgery. So if you had a surgery and the surgery is still intact, so that if you rapidly gain weight after bariatric surgery, you have to go back to your surgeon to make sure that your surgery is still intact. Sometimes you get a fistula, so that's an opening, and then suddenly the bypass is not functional anymore. If that's not the case, you lost weight after bariatric surgery and you're starting to regain, then it means that you have done well, but now you probably need to intensify diet and exercise and maybe use a medication to help you lose that weight again. We have many anti-obesity medications. We have 6 of them, as a matter of fact.
That's actually a great segue to the next question, which is by Lucine Sorbatian. And what she's asking is, what medications would you recommend for morbidly obese diabetic patients for weight loss to use prior to considering bariatric surgery. And she
Great.
goes on by saying most of the meds for obesity are not covered. Thank you.
That's a great question. So if you have obesity and diabetes, you should be on metformin, and you should maximize that dose. Metformin 1,000 twice a day can help you lose weight and improve your glucose control. Then you should also be on a GLP-1 agonist. The best one out there now for diabetes and weight loss is called semaglutide, Ozempic. It's a once-a-week injection, fabulous. It's a tiny little needle, helps you lose weight and get your blood sugar under control. You can also be on what's called an SGLT2 inhibitor, canagliflozin or empagliflozin, which will spill glucose into your urine, get rid of the glucose that way. You can lose weight. So those 3 medications you should be on if you have diabetes and obesity, and those are covered by third-party payers. And I hope you're on those. Do not go on insulin. Do not go on sulfonylureas because they cause weight gain.
Thank you for that. Another question and a comment. Thanks for a lovely webinar. I was wondering if you can speak about what foods or supplements can be used to help reduce inflammation in obesity, such as omega-3 or low glycemic index, as many obese individuals struggle with weight loss. Thank you.
Great question. So what we do in my center, first of all, any diet that is healthy, so lean protein, low fat dairy, fruits and vegetables, and whole grains can be used to help you lose weight. But what we do in our center is we promote a high protein diet, a higher protein diet with less carbohydrates for more rapid weight loss. And that gets the fat right out of the liver and makes you feel better right away. Eventually, you need to stick to a diet that you can stay with forever. So if you don't like to eat chicken and fish and steak and vegetables, you're going to have trouble staying on an Atkins diet, right? So but you should have protein. You should have protein in some form. If you want to go on a Mediterranean style diet, which is high in omega-3s, that's a great idea. Olive oil, salmon, fruits and vegetables, and some whole grains. But when you're on the Mediterranean diet, you've got to be careful of your calorie intake. So usually on a high protein diet, you don't have to worry so much about calorie intake because you're eating a lot of protein, chicken, fish, eggs, and you're eating vegetables. And that's about it. You're cutting out the carbs, and those carbs that you tend to eat too much of are bread, cereal, rice, and pasta. You gotta choose one of these diets that you can stick with.
Thank you for that. We have 2 more questions. One of them is, would you recommend that obese and elderly patients still stay at home after the country reopens? And the second question is, would you recommend patients continue ACE2 inhibitors given the fact of the relationship between ACE2 and coronavirus infection?
Well, I'm not an expert on ACE2 inhibitors or the treatment of hypertension. However, it looks as if you're on medications like lisinopril and ACEs and ARBs, it looks as if you should stay on them. All right, we just don't understand enough about this epidemic and the ACE2 receptor at all, but it looks as if patients who are being treated for their hypertension or their diabetes and are on an ACE2 inhibitor, that's a good thing. Stay on those medications. I'm also not an infectious disease expert, so I'm just explaining why obesity is causing such a difficulty with patients with obesity to have more severe symptoms. And I think that patients with obesity who have diabetes and hypertension and heart disease should be very careful and wear a mask and wash your hands. And as soon as this is over, or even now, start eating healthy, exercising, and seek therapy from an obesity medicine specialist when you can. We're doing telemedicine visits now, so happy to help you out in telemedicine during this pandemic, and then when the country reopens and we can see you in person, we'll do that as well.
Great. And it looks like we have gotten to all the questions. That other question that was pertaining on failed bariatric surgery, that was in regards to a lap band removal. After
Yes.
lap band removal, they qualify. What is the mechanism of the rapid weight gain?
Yes, so if you've had a lap band, so when I say bariatric surgery, I'm talking about the Roux-en-Y gastric bypass and the gastric sleeve, which actually is an operation that changes the anatomy of the GI tract. The lap band, laparoscopic adjustable gastric banding, is a device. It puts a band around your stomach and makes part of your stomach small so that when the food comes in, you've got a semi-obstruction and not too much food can go through very quickly. When you get that band removed, you're going to gain the weight back because you didn't change the pathophysiology of obesity.
It's almost like, the body reverting back to a steady state that for some reason it established.
Yes.
And that's the very interesting, question. And if we were to find that answer, I think that would be the key to, really trying to manage many of these comorbidities that are coming hand in hand with the various metabolic diseases, diabetes, cardiovascular disease, hypertension, and so on.
Yes, we have a pathophysiology. We have for some reason, patients who struggle with obesity are defending a higher body weight set point. And when you lose weight, your body wants you to get back to that higher weight. And the lap band doesn't do it because it's not changing any hormone levels in your gut. It's just a band around the stomach. That's all it is.
Right. That's true. There's Sarkis, you have raised your hand. If you have a comment or a question, we ask you to type that in the chat section or in the Q&A section. Unfortunately, we're not able to allow you to ask the question live, but if you do have a question or a comment, please type it in. And it looks like we did answer all the questions. And
you know what, we had one more question about how the gut microbiome, can you take probiotics to treat the gut microbiome and reduce inflammation? You know what will reduce inflammation and change the gut microbiome is going to be the weight loss. It's going to be the weight loss. And all we know is that when you lose weight and you keep it off, your gut microbiome is different.
Yes.
And
So
you can take supplements, you can take probiotics and prebiotics, and that's better than eating processed food, and that may help. But if it's the processed food that caused the weight gain, and that somehow it has something to do with why your body weight set point is so high, then you got to lose the weight and start eating healthier.
That's right, because it is that the actual weight loss that that
Reduces
will,
the inflammation.
yeah. So we have several more questions that have came in. Can we control obesity by blocking ghrelin secretion?
You know, that's what the sleeve gastrectomy and the Roux-en-Y gastric bypass do. It blocks ghrelin secretion, but it also does other things. So it's not just ghrelin that we have to deal with, but that's a good point. So there are anti-ghrelin, there anti-ghrelin medications that are being tried, but just blocking one hormone is probably not going to cure obesity. When bariatric surgery, you know, causes a BMI go from 50 to 30, it is altering the body weight set point to a lower weight, but you still have obesity. It's altering some of the hormones, but you still have obesity. You're in a much better place. Though, but the hormones are changing, not just one. But that's a very good question. It's going to take more, and we're probably going to discover more hormones that are involved in this very complicated pathway.
Indeed, indeed. We have another, and this will be our last question. And they say, is there any safe methods to train the brain to change eating habits, whether by using medications or psychological means or hypnosis?
Wow. Okay. So we have lots of behavioral interventions that have worked well. And I would recommend that you look up the Diabetes Prevention Program and the Look Ahead study that showed that with intensive lifestyle intervention, you can help patients lose 5 to 10% of their body weight and keep it off at least to 4 years. And then people start to regain weight, but even out to 8 years, there are some people who are keeping that kind of weight off, and some people that lose more. So the behavioral interventions have to do with healthy eating, behavioral strategies, you know, not bringing junk food into the house, exercising, and I would look up the National Weight Control Registry. 10,000 participants are in this registry. Those are people who've lost 50 pounds and kept it off now for 10 years. And what do? They have several things they do in common. They're on a 1,400 calorie a day diet. They eat breakfast, they weigh themselves every day, and they do 2,500 calories of exercise 5 days a week. So those are, so no, 2,500 calories worth of exercise per week, sorry.
Per week. I was going to say, wow. That's,
yeah, no, per week, sorry. So usually they do about 300 to 500 calories worth of brisk walking 5 to 6 days a week. Yeah.
Wow, that's, yeah, that would be a great approach for most of us to follow. One last question, and this is a follow-up question from someone who had asked regards to the medication prior to weight loss medication prior to bariatric surgery, and she asks, any comment on appetite suppressants?
Yes, there we used to have 6. Belviq was taken off the market recently, so now we have 5, but there are several appetite suppressants, but still, many of these are not covered by insurance. So the one that I mentioned is covered, the GLP-1 agonist called semaglutide, which is Ozempic, is an appetite suppressant as well. that's the one you should be on if you can. All right, called Ozempic. But we have other appetite suppressants. We have combinations of phentermine and topiramate, combinations of bupropion and naltrexone. We have liraglutide, which is Saxenda, and we have the good old phentermine, which was approved in 1959. So we do have appetite suppressants.
Thank you.
They can help you lose a little bit more percentage weight than just diet and exercise alone.
Great, great. Dr. Apovian, thank you very much for this really, I mean, to me, it was extremely interesting, and I'm sure it was based on the questions and discussions. You know, this was, I mean, we would love to have you back.
Yeah, I was going to say, you know, I could speak for another hour on treatment for obesity, bariatric surgery and appetite suppressants and diet and exercise. So
we would love to have you back. You know, we will, if you'll make the time for us, we'll definitely create another opportunity, whether in person, when the country opens up and we're able to hold, you know, our CME conferences again. And if not, virtually, we would love to welcome you, you know, back to Southern California.
Oh, absolutely.
And if you ever happen to be here, let us know. We'll definitely arrange a, you know, a dinner lecture and gather our members and our healthcare professionals to hear from your expertise.
I'd love to. I just want to make sure everybody out there stay on your ACE inhibitors, okay? Those ACE inhibitors reduce inflammation, okay? Don't, you know, I was just trying to talk about how the COVID-19 gets in there, but doesn't mean you should stop ACE inhibitors. Very important.
That's true. That is true.
They reduce inflammation. Yeah.
And the various cardiology and hypertension professional societies have also opined and advocated for patients who are on them to stay on them. There's no evidence that
there's data that they're doing better in the COVID-19 crisis. So whatever mechanism is going on, the ACE inhibitor is probably helping. So stay on it.
Great, great. Again, thank you very much, Dr. Apovian, and ladies and gentlemen, thank you very much for joining us on this CME event. We'll continue these series. We'll be back on Monday. On Monday, we are going to have a professor of genetics from UCLA, Dr. Wayne Grody, who's going to talk about genetics as it pertains to predisposition to COVID-19. He's an expert in familial Mediterranean fever, as well as other genetic conditions, part of the Armgenia project that's studying various genetic clusters in Armenians, both in Armenia and the diaspora. And if you if you are wanting to claim CME credits, please go on the website, aamsc.org, and do the post-event quiz, and then you could claim your CME hours. If you haven't renewed your membership, please do so. And if you have any feedback, if you have any suggestions for future events and future topics, please let us know. We truly appreciate your feedback. We know these are difficult times. We're trying to stay connected, taking advantage of various new platforms, bringing to you the latest and the most pertinent scientific information so that we can best take care of our patients, ourselves, our loved ones. And of course, don't forget to spend some time to take care of yourself so that we can best take care of everyone around us. Thank you very much again, Dr. Apovian. Thank you for staying up late with us. I know it's becoming late there on the East Coast. Please stay strong and stay well. And
you too, everybody on the call, stay safe, stay strong, stay well, eat healthy, and exercise. It's great for you. It's great for you.
Indeed, indeed. And on that note, we can't put it any better. Good evening, everyone. Please have a good night. We will see you next Monday. Take care.